Acute pancreatitis. What is acute pancreatitis? Acute pancreatitis refers to acute inflammation of the pancreas. Pathophysiology. It occurs due to attack on pancreas by its own exocrine digestive enzymes. Normally, these enzymes don't attack the pancreas, but, due to either hypersecretion of these enzymes, or accumulation of these enzymes due to obstruction of the outflow tract, then, these enzymes will attack the pancreas. This results in autodigestion of the pancreas. Types of damage to pancreas. It can be classified into two major types: interstitial oedematous, pancreatitis. It is the most common type, with better prognosis. Necrotizing pancreatitis. It is less common, around 5 to 10%, more severe. The damage in acute pancreatitis is potentially reversible. The damage occurring in chronic pancreatitis is irreversible. It results in both endocrine and exocrine dysfunction along with chronic abdominal pain that might be radiating to back. Causes of pancreatitis. Commonly used mnemonic is, I get smashed, idiopathic, gallstones, ethanol, trauma, steroids, mumps or malignancy, autoimmune disease, scorpion sting, hypertriglyceridemia or hypercalcemia, ERCP, endoscopic retrograde cholangiopancreatography, drugs, commonly athioprine, thiazides, septrin, tetracyclines. Clinical features. Number 1. History. Typical symptoms of acute pancreatitis include epigastric pain, typically severe, sudden onset and may radiate to the back, nausea and vomiting, decreased appetite. Other important questions to cover in the history include past medical history, history of gallstones, biliary disease or previous episodes of pancreatitis, past surgical history, recent surgical procedures, for example ERCP, drug history, regular medications and over-the-counter medications, social history, alcohol intake and smoking, family history. Hereditary pancreatitis is a rare cause of pancreatitis. 2. Clinical examination. On abdominal examination, the classical clinical findings may include epigastric tenderness, abdominal distension, due to local reactive eyelash or retroperitoneal fluid, reduced bowel sounds, if an eyelash has developed, evidence of a systemic inflammatory response, indicative of severe pancreatitis. If febrile and hypertensive on admission, the patient is more likely to develop organ failure during their hospital stay. Tachycardia is a less helpful sign, as the adrenergic response can be driven by pain and stress. Cullen's and Gray Turner's sign. Cullen's sign is described as superficial edema with bruising in the subcutaneous fatty tissue, around the periumbilical region. This is also known as periumbilical ecchymosis. Gray Turner sign is an uncommon subcutaneous manifestation of intra-abdominal pathology that manifests as ecchymosis, or discoloration of the flanks. The presence of Cullen's sign and Gray Turner sign are suggestive of retroperitoneal hemorrhage. These are late signs of severe intra-abdominal and retroperitoneal hemorrhage, respectively. Following are presentations of both signs. International Association of Pancreatology. Criteria. It states that 2 of 3 criteria must be satisfied for a diagnosis of acute pancreatitis to be made: abdominal pain plus a history suggestive of acute pancreatitis, serum amylase, lipase of over 3 times the upper limit of normal, imaging findings characteristic of acute pancreatitis. Classification of acute pancreatitis. Classification of acute pancreatitis is governed by the Atlanta criteria: mild, most common, no organ dysfunction, complications, resolves normally within a week; moderate, initially some evidence of organ failure which improves within 48 hours; severe, persistent organ dysfunction for greater than 48 hours, together with local or systemic complications. Furthermore, discrimination was made between 2 clinical phases of pancreatitis: early, first week, in which severity is based on The presence or absence of systemic organ failure. Late, more than 1 week, in which severity is based on the presence of local complication or persistent systemic organ failure. The Atlanta classification divides acute pancreatitis into 2 basic types: interstitial oedematous pancreatitis, necrotizing pancreatitis. All types of necrotizing pancreatitis may be sterile, or infected. Gas formation is the best imaging feature to suggest infection. Terminology for fluid collections associated with acute pancreatitis is fluid collections associated with interstitial oedematous pancreatitis, with minimal, or no necrosis. Acute prepancreatic fluid collections, in the first 4 weeks, non-encapsulated, prepancreatic fluid collections, pseudocysts, develop after 4 weeks. Encapsulated, prepancreatic or remote fluid collections associated with necrotizing pancreatitis, acute necrotic collections, in the first 4 weeks. Non-encapsulated, heterogeneous, non-liquefied material, walled-off, pancreatic, necrosis, develop after 4 weeks. Encapsulated, heterogeneous, non-liquefied material. Investigations, bedside investigations, ECG, a baseline investigation that should be performed for all patients presenting with epigastric pain, to avoid missing the myocardial infarction disguised as epigastric pain. Urinalysis, a routine investigation in acute abdominal pain. However, the urological system is unlikely to be the cause of sudden onset epigastric pain. Relevant laboratory investigations, complete blood count. It is done to detect anemia, that may increase cardiovascular strain, or raised white cell count, part of the SIRS response, CRP. This test is nonspecific. However, elevated levels at admission can be used as an indicator of severity. Urea and electrolytes. The U&E profile includes sodium, potassium, urea and creatinine. Because fluid depletion is extremely common in pancreatitis, so pay close attention to urea and creatinine. LFTs may be deranged, more commonly, but not exclusively, in obstructive causes of pancreatitis, for example gallstone disease. Lipase, very specific, normally 1560 U.L., greater than 3 or more times the upper limit of normal, is highly suggestive of pancreatitis. Serum amylase, 3 or more times normal, is suggestive of pancreatitis, less specific than lipase. Venous blood gas, VBG, rapid method to assess pH, electrolytes, HB and lactate. Arterial blood gas, ABG, essential for prognostic scoring in acute pancreatitis, provides a more accurate acid-base balance and true PaO2/CO2, compared to a VBG. Beta-HCG, should be checked in all women of childbearing age, not only to rule out ectopic pregnancy, but also to permit investigations such as X-ray and CORT safely. Imaging. The diagnosis of acute pancreatitis should be made clinically. However, imaging is sometimes used to support the diagnosis or rule out other pathology. Relevant imaging investigations include erect chest X-ray, used to look for free gas under the diaphragm, pneumoperitoneum, in patients who present with epigastric tenderness. Abdominal ultrasound, a useful investigation to assess the biliary tree for evidence of obstruction, for example biliary dilatation. The pancreas can sometimes be assessed using abdominal ultrasound, for example evidence of edema may be noted. However, the presence of bile gas often obscures the pancreas, making assessment difficult or impossible. CORT abdomen and pelvis, used to exclude other causes of severe abdominal pain, and assess for complications of pancreatitis, for example pseudocyst formation. CORT provides optimum imaging of the pancreas, and is typically performed at 48-72 hours after the initial presentation. If patients do not clinically improve, to assess for evidence of pancreatic necrosis or other complications. Prognosis of pancreatitis, Glasgow-Emery score, Ranson's criteria, BISAP score, Glasgow-Emery score, determines severity of pancreatitis based on 8 laboratory values. These criteria are traditionally scored with values at 48 hours after admission. This severity score can be easily remembered using the mnemonic, pancreas. Each criterion gets 1 point, and severe pancreatitis is indicated by a score of 3 or more. PaO2, less than 59.3 mm mercury, age more than 55 years, WBC more than 15 by 10 A³ per microliter, calcium less than 8 mg per deciliter, BUN more than 44.8 mg per deciliter, serum urea more than 16 millimoles per liter, LDH more than 600 L, albumin less than 3.2 gram per deciliter, glucose more than 180 mg per deciliter. Another criteria is Ranson's criteria for pancreatitis. Ranson's criteria is used to predict mortality from pancreatitis, calculated on admission, and at 48 hours. To estimate mortality from pancreatitis, there are 5 criteria on admission: WBC, age, glucose, AST, LDH. There are 6 criteria to note after 48 hours, that are compared with values on admission. To see the change in these values, H, C, T, B, U, N. Calcium drop. Arterial PaO2. Base deficit. Fluid needs. The third criteria is BISAP score for pancreatitis. Mortality predicts mortality risk in pancreatitis, with fewer variables than Ranson's. Data should be taken from the first 24 hours of the patient's evaluation. The BISAP is a more recent score than the older Ranson's criteria, and does not require data points from 48 hours into a patient's hospital admission. It includes following 5 criteria: B, U, N. More than 25 mg per deciliter. Impaired mental status, defined as disorientation, lethargy, somnolence, coma or stupor. More than or equal to 2S, I, R, S. Criteria, age more than 60 years, pleural effusion present. Immediate management of acute pancreatitis. Immediate management of acute pancreatitis should include intravenous fluid resuscitation, and correction of electrolyte disturbances, analgesia, intravenous paracetamol and opioids, antiemetics, nil by mouth, until initial pain improves, control of blood glucose. Current evidence suggests that routine antibiotic use for acute pancreatitis does not provide any benefit to patients and therefore should be avoided. In the context of pancreatic necrosis, antibiotics are often used prophylactically due to the increased risk of infection. Specific management depends on the underlying cause of pancreatitis. Patients with biliary obstruction often require an ERCP. Complications of pancreatitis. Early complications of acute pancreatitis include necrotizing pancreatitis. Infected pancreatic necrosis occurs when necrose in pancreatic tissue becomes infected. Patients require antibiotics and necrosectomy. Pancreatic abscess occurs when prepancreatic collections of fluid become infected. Urgent drainage is required. Acute respiratory distress syndrome, associated with the SIRS response of acute pancreatitis. Typical chest X-ray appearance of widespread bilateral pulmonary infiltrates. Late complications of acute pancreatitis include pancreatic pseudocysts, collections of fluid that are not surrounded by epithelium. They are typically amylase-rich and can become infected, rupture or bleed. Pseudocysts typically accumulate within 4 weeks after acute pancreatitis. Only 40% resolve spontaneously, therefore intervention is usually advised. Drainage or excision, portal vein or splenic thrombosis, secondary to ongoing inflammation, anticoagulation required. Chronic pancreatitis, Repeated attacks of acute pancreatitis can lead to ongoing inflammation and fibrosis of the pancreas. Pancreatic insufficiency. The exocrine function of the pancreas is more commonly affected, whilst the endocrine function is typically maintained.